Hello and welcome. I'm Farah Douglas, President and CEO of the Liver Health Foundation. Tonight's educational webinar is about cirrhosis and hepatic encephalopathy, known as HE. Cirrhosis is a condition where the liver is seriously scarred, leading to liver failure. Liver transplantation is often the only treatment option for patients with end-stage liver disease, including cirrhosis, of course. Patients with cirrhosis are at risk of various complications. One of these complications is hepatic encephalopathy, or HE, a brain disease that is characterized by loss of brain function, confusion, altered level of consciousness, and coma that happens when the liver is unable to remove toxins from the blood. During this year's Salute to Excellence in Liver Care event in October, we introduced Aaron Jackson, a liver and kidney transplant patient. Aaron talked eloquently about his HE while he was awaiting his liver transplant. He talked about altered state of consciousness, strange and fantastical dreams, and not being able to recognize his family members. He told us how awful it was to feel that he's in this world all alone, on his own, and nobody knew nobody. Now, after his double transplant, he has regained his brain functions and memories and is able to recall and explain what he experienced as a result of kidney and liver failure. In tonight's webinar, Dr. Jeffrey Kahn will offer a comprehensive review of cirrhosis and HE through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Khan, Dr. Ayub, Dr. Hu. During the roundtable discussion, our experts will talk about their own experiences in working with cirrhosis and HE patients and their research on this disease. If you have any questions, please post them on Q&A or chat function. Our experts will try to respond to your questions. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with a mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and portions of Northern California. Now the disclaimer. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, pharmaceutical companies, or any treatments. This program has been made possible by an educational grant from Mallinckrodt Pharmaceuticals. We thank Mallinckrodt for their support. We are grateful for Salix Pharmaceuticals educational grant, which has been instrumental in bringing this webinar to you. It is my privilege to introduce Liver Health Foundation's longtime friend, Dr. Jeffrey Kahn, who has generously agreed to be the presenter for tonight's program. Jeffrey Kahn, MD, is Associate Professor of Clinical Medicine, Medical Director of Liver Transplant Program, Keck School of Medicine of University of Southern California, USC. Dr. Kahn received his fellowship training in gastroenterology and transplant hepatology from the Keck School of Medicine and Cedars-Sinai Medical Center in Los Angeles. He is board certified in internal medicine, gastroenterology, and transplant hepatology. Dr. Kahn's primary research interests are in liver transplantation, hepatocellular carcinoma, and viral hepatitis. He has written and co-authored several abstracts and peer-reviewed articles on various topics such as chronic hepatitis C and liver transplantation. Dr. Kahn is a distinguished lecturer and a member of the Liver Health Foundation's Medical Advisory Council. We were honored to acknowledge Dr. Kahn's expertise and his compassionate care of liver patients in 2023 by presenting Liver Health Foundation's Excellence in Healthcare to Dr. Kahn and Liver Transplant Program at Transplant Institute, USC. Dr. Khan, welcome to Liver Health Foundation's educational webinar. I thank you for your continued support. We are ready for your presentation.
Great. Thank you very much, Farah, for the introduction. Let me just share my screen. Go. 1 second. Okay, can you see my screen okay?
Yes.
Okay, great. Yeah. Thank you very much. It's a pleasure to be here and talk to the group on cirrhosis and some of the complications. And Farah had asked me to talk more extensively on protosystemic encephalopathy, which is the altered sensorium that we often see in patients with various forms of liver disease, especially in cirrhosis. So I'm going to spend a little extra time talking about encephalopathy. Oops, okay. So just want to reiterate that this is general information and not to be taken as sort of personal medical advice. And please talk to your physicians or your family member or friends' physicians. So first of all, what is cirrhosis? So Farah had mentioned that it's scarring in the liver. And we know that various liver diseases, many of which are listed underneath here, can actually cause varying degrees of scarring in the liver, and everything from minimal to very advanced. And patients often, ask me like, how bad is their cirrhosis? What percentage of my liver is not functioning? And cirrhosis is cirrhosis, and once you have cirrhosis, then there are different stages, which I'll talk about in a moment. And then there are different ways to sort of tell how severe the cirrhosis is, and maybe when we should be thinking about liver transplantation, which is usually when we're talking about decompensated cirrhosis. And I'll get into that a little bit. These days, the most common things that we see causing chronic liver disease and cirrhosis or alcohol-associated liver disease, and what we used to call NASH, or non-alcoholic steatohepatitis, which we now call MASH, which is metabolic dysfunction-associated steatohepatitis. And then there are sort of combinations of MASH with alcohol, and we call that MET-ALD. Hepatitis B and C. Hepatitis C is, you would think, quite eradicated, but actually there's just as much hepatitis C out there now as there was in the past. It's just that we're seeing the people that we sort of capture and treat, and there are a lot of people out there that are untreated, and they actually are sort of sources for other people developing hepatitis C. So it's really important, such as diseases like polio, to try to eradicate hepatitis C completely, and there's a big push toward what we call hepatitis C elimination. Hepatitis B is a disease that we can't really cure, but we can make it very, very quiet. And I do think that within the next 5 or 10 years, almost everybody who has hepatitis B will have at least very, very quiet hepatitis B, which we call functional cure, and not need to be on oral medications. And many of you in the audience may be on medications for Hep B. So we might, the landscape's going to be changing very shortly. Certainly the autoimmune liver diseases, most notably autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and then variants that may combine these various entities. Hemochromatosis and alpha-1 antitrypsin deficiency, which are genetic diseases, and I put Wilson disease last. It tends to be a disease of younger patients or younger people, really important to treat because the manifestations of Wilson disease can be quite severe. And the last time that I did one of these webinars, it was on Wilson disease, and I have a bunch of patients with Wilson disease. So in terms of disease severity, this is two different ways that we kind of look at disease severity. One is called the Chiles-Turcotte-Q classification, which looks at various clinical and laboratory manifestations. And we'll talk a little bit later about what some of these things mean. But encephalopathy, which is the altered sensorium that we sometimes see, ascites, which is buildup of fluid in the abdominal cavity, and then 3 laboratory tests: the bilirubin, the albumin, and the prothrombin time, or INR test. And basically you assign points based on severity. And if somebody has at least 5 points, they have cirrhosis. The scoring, though, goes from 5 to 15. So the more points somebody has, the more severe the cirrhosis. So all of these people would have cirrhosis, but the more points, the more severe. We tend to use the model for end-stage liver disease, which is MELD score. Now we go by something called the MELD 3.0 score. And this is a different way, which purely looks at laboratory tests plus a couple of other parameters, which I'm going to show right here. So as of this past year, instead of the MELD score, which many of you are probably familiar with, which included bilirubin, sodium, INR, and creatinine, now we added albumin and we added the gender or sex for purposes of adult MELD calculation. And this is how somebody identifies their gender to be, not necessarily their birth gender. The major reason that we included gender in this is because females tend to have lower creatinine levels, which is this test for kidney function, because this is based upon muscle mass. And so patients who are females with lower muscle mass might have the same disease severity but have a lower MELD score, and we found that there was a disparity in terms of getting patients transplanted for livers, at least partially because of that. And we know that in patients who are on gender affirming programs taking sex hormones, for instance, a male gender or male at birth who is on estrogens will actually have a lower muscle mass and technically have a lower creatinine with a similar amount of liver kidney dysfunction compared with somebody who has a higher muscle mass. So they would actually qualify if you're talking about liver transplantation. And just to give you an example, this would be a female with the same laboratory test would have a MELD score of 21, but a male, it's hiding under my thing here, but it would have a MELD score of 20. And in some places, that would be actually the difference between actually being able to get a liver transplant someplace. So it is quite important. Quite a while ago, they were actually considering just assigning a few extra MELD points to females in general, and that's kind of what ended up happening here. So I think hopefully we'll find out more soon whether the sort of gender disparity has been at least partially rectified in terms of liver transplantation. We do know that the MELD score, which goes from 6 to 40, as you go up in MELD score, the sort of survival decreases, and that's because the patient's liver disease is more advanced. So again, the CTP classification that we talked about in the MELD score are two different ways, but two complementary ways of looking at how somebody's doing. Oops. So in terms of the natural history, liver scarring usually progresses very little, really over decades. We know that for hepatitis C, which we don't see a lot of anymore in our clinics, the average time for a female developing cirrhosis from infection is about 30 years, and for a male is about 20 years, and that's in non-immunocompromised people. In people that are immunocompromised, such as uncontrolled HIV or post-organ transplants without suppression of the hepatitis C, for instance, it could be only 10 years. For most other diseases, it's over decades. And I see a lot of patients in their 9th and 10th decade that are diagnosed with cirrhosis who actually had never been diagnosed before. And many of them have no symptoms and really have had probably cirrhosis for many, many decades. Usually there are no symptoms until the disease is more advanced. I would say the most common symptom patients can, sort of retrospectively complain about is fatigue. And it's by far the most common symptom that we see in patients with cirrhosis is fatigue until they develop more of these other symptoms that I'm going to talk about now. So once liver function starts worsening, we start to see symptoms, and I'm kind of mixing up signs and symptoms and organs here because that's sort of how it works. So jaundice is yellowing of the whites of the eyes, the skin, and often with dark urine, and that's due to abnormal handling of bilirubin and buildup of bilirubin in the blood, which is a byproduct of red blood cell destruction. We have turnover of our red blood cells every so often, and with the turnover, bilirubin is formed, and we get rid of it by processing it in the liver and excreting it in the liver into the bile, and also to some extent into the urine. So when the liver isn't working so well, the bilirubin goes up. Kidneys and lungs and heart can be affected by liver disease as well in varying degrees. We know that patients with very advanced liver disease often have kidney failure, something that we call hepatorenal syndrome. And some of these people end up on dialysis and have symptoms related to their kidneys. Some of our patients have shortness of breath because of effects on the lungs. They can have what we call a cirrhotic cardiomyopathy, where the heart muscle gets involved. We can have GI bleeding. Many of you may be familiar with esophageal varices, gastric varices, portal gastropathy, which is the lining of the stomach can bleed, the lining of other organs in the GI tract, such as the duodenum, which is part of the small intestine, all the way down to the rectum, actually. So any area can be involved. Sometimes we actually see bleeding from what we call, in lay terms, watermelon stomach. Ascites is very common. Fluid builds up in the abdomen. It can go into the lung, and we call that a hydrothorax. The fluid can get infected, and we call that spontaneous bacterial peritonitis, and these are very serious infections. And again, these are all evidence that there's decompensation, and these are times that we start really trying to think about liver transplantation, hopefully, before these become very, very advanced. Liver cancer is quite common. We, as many of you know, we do surveillance with imaging and tumor markers in general every 6 months. There's some data that actually doing 3 tumor markers is probably just as good. And eventually we're probably going to be getting away from doing, say, ultrasound surveillance and doing just tumor markers. And if they are abnormal to a certain degree, then doing some sort of contrast imaging, such as an MRI or a CAT scan. Those are studies that are in progress. That's not the sort of standard right now. And right now we're doing ultrasounds and alpha-fetoprotein tumor marker tests in general every 6 months, but every provider, may have their own way of doing this, but in general, every 6 months. So people often ask about treatment. So certainly for jaundice, we really don't have specific treatment for jaundice unless there's a flare of hepatitis B, in which treating the hepatitis B would make the bilirubin get better. If somebody has a new clot, say in the vein going to the liver, if we can remove the clot, that might make it better. A lot of times it's just development of tumor in the liver or just decompensation. And so really jaundice is not an easy thing to get rid of. We can't really dialyze away jaundice. For many liver, kind of problems, jaundice is sort of the last thing to start and the last thing to go away. So for instance, if somebody has a drug-induced liver injury from something, even acetaminophen, usually the bilirubin, which makes people jaundice, is the last thing to go up. And then oftentimes it's the last thing to come down. Edema, which is the fluid in the legs and other areas under the skin, and ascites. The major treatment for that would be salt restriction and diuretics. And salt restriction is really important because we know that the amount of sodium taken in or salt taken in is directly proportional to the amount of fluid buildup. And our recommendation is generally a 2-gram sodium diet, which is 2,000 milligrams of sodium chloride. And 2,000 milligrams of sodium chloride is the equivalent of less than a teaspoon of salt, of table salt, that one should be consuming on a daily basis. So that includes what's in the food and what somebody adds to their food. So if something tastes salty or somebody's adding salt to their food, it's definitely going to be too much, and it's going to be hard to control the ascites and edema. We also know that we need to often add diuretics, and we add diuretics are medications that decrease sodium or salt uptake in the kidney. And we know that when the kidney takes up salt, it also takes up water, and then the fluid builds up. So we try to get rid of the sodium in the urine by giving diuretics. And what we want is somebody to be in what we call a negative sodium balance, which means if you could measure, say, the amount of salt that comes out in the urine, we want that to be greater than the amount of salt that somebody takes in, and that's the goal of treatment. If there's infection, we want to treat with antibiotics. So if somebody has infected ascites, we treat it. Depending on the organism and depending on the severity, that tells us how long we would treat somebody. Once somebody's had a infection in their ascites, then we tend to treat those patients long term, really to suppress any infection from coming up. GI bleeding is very, very common. We tend to use something called non-selective beta blockers. Many people might be familiar with a drug called Lopressor, which is a cardio-selective beta blocker that often is used by cardiologists. It turns out that the non-selective beta blockers, especially carvedilol, which is probably the best, and then propranolol, which is probably second best, actually decreases the amount of pressure in the vein going to the liver. And it also decreases, especially carvedilol, resistance in the liver. So it actually decreases the pressure, decreases pressure in what's called the portal vein, which is the vein going to the liver, and actually decreases the risk of actually bleeding from these varices. If somebody has a bleed, we tend to use band ligation. This is a picture here showing, let me just move this out of the way. So this is actually the vein going, this is the vein going to the liver right here. And what happens is the pressure builds up and we end up with what we call collaterals or varices that are forming, and that's what these are. These are potential veins that we all have, and if the pressure builds up in the vein going to the liver, the blood tries to find its way to get back up to the heart, so it goes around the esophagus and around the abdominal cavity. When we do an endoscopy, we put a scope into the esophagus, so the mouth would be up here, and the stomach would be down here, and this is the esophagus, and these sort of purplish raised areas are actually veins that we can see through the wall of the esophagus, and we have a little thing on the end of the endoscope that actually, and I'll show you a picture, that sort of sucks up the varices and puts a little rubber band around it, and I think I have that on the next page here. So this is not a great picture of a varix, but this is actually a rubber band after it was deployed on a varix. Sometimes when there's really bad bleeding, depending on the circumstances, or bleeding from the stomach, from varices in the stomach, we sometimes do something called a TIPS procedure, which is a procedure where the interventional radiologist connects the vein going to the liver with the vein coming from the liver, and this sort of bypasses much of the liver and decreases the pressure, so the vein pressure in this portal vein goes down, and those varices that I showed you before then become decompressed, and the patients hopefully don't bleed anymore. And we do a fair number of these. Years ago, they used to get clotted and clogged, but now we have much better stents that actually have quite a long durability. And this can also be done for people with ascites buildup and people with fluid in the lung, as long as their liver disease isn't severe or isn't too severe. We do TIPS for patients with very severe liver disease if they're high risk for rebleeding or we can't control it, because we know that in somebody with a very bad liver disease, bad rebleeding actually is more dangerous than putting the TIPS in, and we know that the outcomes are better with a TIPS than not doing a TIPS in the proper patient. But we do a fair number of these TIPS procedures. And finally, I wanted to talk about portosystemic encephalopathy. I just wanted to sort of clarify, in the hepatology world, we sort of differentiate between hepatic encephalopathy, or HE, and portosystemic encephalopathy, which is PSE. I tend to think of hepatic encephalopathy as somebody who has acute liver failure, where the liver's failing, all sorts of things are being put into the bloodstream that get into the brain and cause altered sensorium. And that's very different than portosystemic encephalopathy, which is really due in part to ammonia getting out of the, not being filtered through the liver properly and getting around the liver. And so when it gets around the liver, it gets up into the bloodstream. So the liver has a lot of functions in terms of detoxifying, and one of those is detoxifying ammonia. And one of the ways that the ammonia is detoxified is actually by making something called urea, which is something that ends up in urine. And it's usually reversible if we have features that we actually can, if we can reverse the precipitating factor. If we can't, then it may not be reversible. And I know that Farah had shown that there were some questions about sort of what kind of sort of manifestations a patient might exhibit. It might be very, very subtle mood or personality swings. Oftentimes, patients talk about problems with memory, concentration. Very, very early changes might be a change in handwriting or just very subtle word finding. And in some cases, people even think the patient had a stroke or something like that. But again, very, very varying manifestations. I've had patients that were very, very angry. I had a very, very nice patient that actually bit his wife. And this was like the kindest gentleman I probably ever met, and it was just a manifestation of poor systemic encephalopathy. I had a patient who thought that I was in the FBI, part of the FBI, and I was out to investigate and arrest them. So all sorts of manifestations, and everybody's manifestations are a little bit different, and they can be different at different times. So I think the most important thing as a caregiver is to look for subtle changes. There are a lot of instruments that we can use to look for subtle encephalopathy. And I think that there'll be instruments that we'll be using even for people to be using at home that could be transmitted to their physicians or caregivers to let them know if there's something that's about to happen or subtly happening. Because one of the most common indications for admission into the hospital is encephalopathy. And oftentimes it's because it was kind of caught late or treated late. A lot of times the patients don't like the medications they get for it, and so it gets precipitated. So if we can catch it early, we could probably prevent a lot of hospitalizations. And we know that when patients with liver disease and encephalopathy get hospitalized, they actually, it causes a lot of agitation, just just being in the hospital, because it's an unfamiliar place, and all sorts of things can provoke it and actually make it worse. So we're much better off treating mild encephalopathy at home if we can. So the grading system, I think somebody had asked about the sort of stages or grades. So really grade 0 is minimal, and these are things that you might notice something subtle if you're really close to somebody, or we might have to do some more sort of testing, that we do something called the Stroop test, and there's some other tests that we sometimes use. Grade 1 is very mild, and then grade 4 is coma. So the worse, the higher you go up, the worse it is. In somebody with a grade 4 or a coma, these are people that might need to be on a respirator just to help protect them from vomiting blood and keeping them breathing okay, vomiting and aspirating into the lungs rather, and keeping them breathing okay. And the worse the encephalopathy is, the more difficult it is to get the patients out of encephalopathy. And we'll go over some of the treatments, I think, on the next slide. Oh, no, I'm sorry. Okay, so precipitating factors. Infection is one of the most common. Anybody with encephalopathy, we should look for infection. If they have ascites, it should be removed to look for infection. Look for urinary tract infections and other things. Electrolyte disturbances, especially, I would say, hypokalemia, hyponatremia, that's low potassium, low sodium, oftentimes precipitated by diuretics. GI bleeding, because blood in the gut, bacteria love to consume blood in the gut. Those bacteria make ammonia, which gets absorbed and causes bleeding and causes encephalopathy. Worsening liver function. So if the liver is getting worse, the liver mass is getting worse, and there's less handling of things like ammonia and other things that can cause encephalopathy. After a shunt procedure, such as the tips that we talked about, sedatives, especially benzodiazepines and narcotics. Just a mention of benzodiazepines, so things like Xanax, things like Valium. We know that if we take somebody with encephalopathy and give them drugs, one of the drugs is called midazolam, which is a drug that we use sometimes for endoscopy. It can actually sort of make somebody, it can mimic encephalopathy. And if we give the antidote to midazolam in somebody who never got any kind of benzodiazepine, sometimes the encephalopathy gets better. So we think that benzodiazepine like receptors in the brain may get stimulated in people with encephalopathy, even who don't get benzodiazepine. So obviously you give Ativan to somebody with cirrhosis who's prone to encephalopathy, they can actually get pretty confused. Narcotics, really anything that can alter the sensorium. And then constipation, because those bacteria in the gut that break down products in our that breakdown products get produced, and they produce ammonia. The ammonia gets absorbed into the bloodstream and can cause encephalopathy. So if people are constipated, the stool isn't moving through as fast. The bacteria are sitting there longer, producing more ammonia, and the ammonia is causing encephalopathy. So we'd like people to move things through. Then there's something called a spontaneous shunt, which I wanted to sort of mention because sometimes patients will be sort of doing great at home and then suddenly they become completely confused and sometimes what we call obtunded, where they're barely even coherent or incoherent. And I showed you a picture similar to this before. So this is something called the superior mesenteric vein, the vein coming from the gut. This is the splenic vein, the vein coming from the spleen, and that joins to make what's called the portal vein, which is the vein that goes into the liver and then eventually connects up with veins that go up to the heart. So it turns out that some patients can develop these collaterals that we talked about, such as varices, but some people actually develop connections between the kidney vein on the left side, called the left renal vein, and the spleen or splenic vein. And what happens is if the pressure builds up, blood starts dumping into this vein that leaves the kidney, can actually go into this big vein that goes right to the heart, and is essentially a shunt like that TIPS I showed you before. It dumping blood right into the bloodstream that's not filtered by the liver, and that can cause pretty severe confusion and pretty severe sudden confusion. So if we have patients that have recurrent confusion, especially dense confusion that occurs really suddenly without any obvious provoking factor, we need to be thinking about perhaps one of these shunts. And the reason it's important is that sometimes these things can be closed up and the confusion or encephalopathy can actually get better. So what are the treatments that we use? So one of the mainstays is lactulose. So we know that lactulose actually causes the stool to become acidified or acid-like, and ammonia gets converted into something that doesn't get absorbed into the bloodstream. And if it doesn't get absorbed into the bloodstream, then that significantly decreases the likelihood of getting confused. It also treats constipation. The problem is it causes bloating, in some people profuse diarrhea. It could raise the sodium because it pulls water out of the bloodstream and can make the blood be more concentrated. One of the main reasons that people with cirrhosis on lactulose come into the hospital with encephalopathy is because they don't like the side effects and they don't take it. So it's important for any patient to really be open with their provider and let them know if they're just not tolerating it, because we have other options. Miralax is very commonly used for constipation. It actually, in some studies, is just as effective as lactulose and oftentimes doesn't cause the same amount of bloating and less symptoms. Rifaximin is an antibiotic which decreases the bacteria in the gut and decreases ammonia production. I talk a lot about diet. It's very important. When I was training, we were told, patients with cirrhosis shouldn't have a lot of protein. Actually, they need a lot of protein, but don't bolus protein. We want people to have, more protein than people without cirrhosis have, because their bodies are breaking down muscle and they need to replenish muscle with protein and amino acids. But we don't want people to have a lot of protein at one sitting. So I recommend the patients always see our dietitian or one of our dietitians, and they recommend sort of more frequent meals with protein. We also like patients to have a protein snack before bedtime, because that sort of helps with their catabolic state, going to bed with some protein on board. Zinc might help with some of the enzymes in the liver that help with ammonia metabolism. L-carnitine is a substance that actually may help some of the cellular what we call organelles function better, and again may be working with ammonia metabolism. And then in some cases we need to do a liver transplant if somebody has debilitating encephalopathy that we can't treat, because bad encephalopathy can be very dangerous. People fall, they break bones, they have bleeds in their heads because they hit their head, and their quality of life can be very, very bad. So liver transplantation is something that we sometimes do because of bad encephalopathy. If the encephalopathy is very bad and very long-standing, sometimes it doesn't actually get better or that much better. So we want to catch it kind of early, treat it, and if it seems like it's just going in the wrong direction, maybe get people transplanted sooner than later. Whoops. All right, so I think that's it for my slides. And I know I wanted to sort of open it up for a bunch of questions. I know that Farah had a bunch of questions that were sent in before, and maybe she can lead the rest of this. So
Sure. Thank you so much, Dr. Khan. This was a very detailed and good presentation for people who are not doctors to understand. You actually talked about something that I personally have questioned, and hopefully we'll get a chance to talk on roundtable discussion. So now we will start the second half of the webinar, the roundtable conversation with our guest experts who will talk about cirrhosis and HE and will respond to the questions we have received. I'm delighted to introduce Dr. Walid Ayub, another longtime friend of Liver Health Foundation. Walid Ayub, MD, FAA, SLD, AGAF, Professor of Medicine, founder and Director, Autoimmune and Liver Disease Program, Associate Medical Director, Liver Transplant Program, Cedars-Sinai Medical Center, Department of Medicine, Karsh, Division of Gastroenterology and Hepatology, Comprehensive Transplant Center. Professor Ayub conducted fellowship in hepatology and gastroenterology at Cedars-Sinai Medical Center and UCLA, respectively. He then became clinical assistant professor of medicine at the Stanford University until 2012, when he moved back to Cedars-Sinai Center, where he is currently professor of medicine, director of autoimmune and cholestatic disease program, and associate medical director of the liver transplant program. Dr. Ayub is board certified in gastroenterology and transplant hepatology and has been involved in several clinical trials investigating pharmacological therapies for liver impairments, MASH, primary biliary cholangitis, known as PBC, primary sclerosing cholangitis, known as PSC, liver cancer, and viral hepatitis. Dr. Ayub has published and served as a reviewer of prestigious journals such as the American Journal of Transplantation, Liver Transplantation, Journal of Clinical Gastroenterology, Journal of Hepatology and Digestive Diseases and Sciences. Dr. Ayub is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Ayub, welcome. Thank you for supporting our efforts.
It's my pleasure.
Thank you. It is my pleasure now to introduce Dr. Hu has been working with us since 2014. Jin Hu, MD, FAA, SLD, Director, Hepatology Services, H.H. Chow Comprehensive Digestive Disease Center, School of Medicine, Professor of Clinical Medicine at the University of California, Irvine School of Medicine. Dr. Hu received his medical education and training in Tongji Medical University, China. After his residency at Huntington Memorial Hospital, Pasadena, he completed a fellowship in hepatology at the University of California Liver Unit. Dr. Hu was awarded with FAA SLD designation and being a part of the inaugural class of AASLD Fellows in 2014. Dr. Hu has a long-standing research interest in basic and clinical research of viral hepatitis B and C and primary liver cancer. His current clinical research focuses on understanding how hepatitis B virus and hepatitis C virus infection is associated with fatty infiltrates in the liver and disease progression, and how viral hepatitis B and C are associated with liver cancer. As an active investigator, Dr. Hu participated in several important trials that test new treatments for Hep C and B. Currently, his laboratory focuses on searching new chemoprevention of liver cancer. Besides active involvement in clinical trials of hepatitis B and C treatment, Dr. Hu's clinical research also focuses on natural history and outcomes of liver disease and healthcare disparity. Dr. Hu has co-authored more than 100 research papers, book chapters, and review articles. is dedicated to community outreach and services, public health education, and reduction of healthcare disparity in Asian American. Is the advisory board member for several local and regional health promotion organizations, including serving on the Liver Health Foundation Medical Advisory Council. Dr. Hu, welcome to the webinar. Thank you for your participation and continued support.
Thank you, Farah.
Oh, you're very welcome. Thank you. Over the past few days, I have received questions about this subject that I have presented them to our doctors. If you have questions, please post them on Q&A or tab function. To start the roundtable, one of the questions was, I can do the first question and then we will review the other questions and talk about them. And one of the audience had asked, which is the best for examining a tool for the liver fibrosis, MRE, LE, or biopsy in the earlier stages of liver disease? Dr. Khan, would you like to comment on this?
Yeah, that's a good question. So, I tell patients, so MRE, well, let's start with a liver biopsy. It shows us a little tiny piece of liver. We do the transit elastography or like FibroScan or the different ultrasound modalities, shows us about maybe 50 times that amount, but it's a very thin piece. MR elastography shows us the whole liver. But the problem is, none of these are perfect. So the liver may not be homogeneously scarred. And there could be false negatives and even false positives, especially from MR elastography and from FibroScan. And so, the problem is we have to sort of look at the whole picture. Do we think the patient has more advanced fibrosis? If the testing we're doing doesn't show that, then we keep investigating. So I don't think there's an actually right answer to that. And I've had cases where a liver biopsy looked different than a FibroScan, looked different than MR elastography. So that's a very challenging question. In general, I think for the FibroScan test and the MR elastography, what I call the negative predictive value, meaning if the test comes back normal, there's a pretty good chance it's normal, but I think there's a decent chance if it comes back with high degree of scarring that there may be an alternative explanation. So we have to really look at it in context. I'd be interested in what my colleagues, what their experience has been.
Dr. Ayub?
I agree with Dr. Khan. Liver biopsy samples, sliver of the liver, very thin part of the liver, and we assume it represents the whole liver. So you have to take it with a grain of salt sometime. Transient elastography or a FibroScan, it looks at a square, one square area of the liver. So we assume it represents a whole liver. The MRE looks at the whole liver, and it gives us what I call a heat wave, where actually we could tell where the scar tissue are, and then the software of the MRE give us an estimate how much scar tissue there is. Now, if you take the appropriate clinical setting, as Dr. Khan mentioned, you exclude stuff that the situations that would make the MRE or the liver elastography falsely positive, then you could comfortably come to a diagnosis or assessment of the fibrosis, but you have to take the clinical setting. For example, someone with a heart failure, no matter which study you do, elastography or MRE, you will get false positive result. So that's one thing. That's why the clinical judgment is important.
Dr. Hu?
Yes, I think Dr. Khan's Dr. Ayuba was had great summary about that too. They have different utilities too. They're not perfect, but they may have different utility too. So if we look at it really, sometime we need to look at a tissue level, like autoimmune hepatitis, rejection after liver transplantation, FibroScan, MRE will not tell anything. So that's something we needed. But in general, if you want to see scar, fatty liver, I think FibroScan, MRE could do relatively good job. But I think both are very quite right too. There's no way to be perfect. They have different roles here too. And keep in mind, liver biopsy is invasive. We have to put a needle to our body. So we cannot do that frequently. So, and also expensive too. It does carry complications too. So, but both elastography and MRE could be less invasive too.
Yes, okay, very good. Dr. Khan, you refer to some life changes, lifestyle changes. Can I hear from all of you about what kind of lifestyle changes? You talked about salt, which is something that really mostly know about and try to avoid. What other lifestyle changes? Exercise, eating. What can a cirrhosis patient do to not make it go faster toward the end and just slow down the progress?
Who wants to go first?
Okay, I think I go first. Lifestyle changes include so many things, different things too. Because liver disease can be caused, as Dr. Khan mentioned, infection, the virus, can be metabolic related to, and it can be any other things too. And the people with cirrhosis, the lifestyle is different than prevention, the other liver diseases too. So like for viral hepatitis, it's contagious. Most time is gonna be blood-borne disease. So we don't want to contact body fluid from patients with infection. And then we have vaccine to protect ourselves too. Those are viral hepatitis A, B, C. Hepatitis A, maybe we got it through the trial, through the travel into developing countries too. So the hygiene, the food hygiene is going to be important too. That's in general for viral hepatitis. Metabolic diseases really, we talk about many things, overweight, diabetes, and high cholesterol, and also alcohol use. That's a big one.
Yes.
So that's in general. And then when talk about cirrhosis, you mentioned that too. I think Dr. Kang mentioned that two things. One is low salt diet when they have cirrhosis, and when they have encephalopathy, we want them to take a protein, but we don't want to take a large amount of protein one time, bolus protein. So that's in general. I mean, Dr. Kang and Dr. Walid can add something too.
Yeah, I mean, Farah, it's easy to tell a patient you need to be on a low salt diet, but what I do is actually I spend good amount of time explaining what that means to them. A lot of patients are surprised that they cannot have sushi, for example, or soy sauce or fish sauce containing food. And depending on their ethnicity, that could be life-changing for them. But then canned food, canned soup, all of these are a big no-no for someone with cirrhosis. Alcohol is a big no-no. There is no such thing as alcohol-free beer. So even O'Doul's or any other brands that they are advertised as alcohol-free beers are not allowed for patients with cirrhosis. It makes their liver work much harder. So it's a lot of lifestyle. The other important part is exercise. It's very important for patients with cirrhosis to maintain their muscle mass. Dr. Khan mentioned ammonia. Muscles use ammonia as a source of energy for it to work. So the more muscle a person with cirrhosis has, the less work the liver has to do. And if they lose their muscle mass, the liver has to work harder to make up for that loss of function that the muscle used to do. So exercise is very important.
I'd like to also add regarding the exercise, because I'm a big proponent of that for anybody, but especially for patients with liver disease, because number one, there's a big sort of interest in something called myosteatosis, which is actually fat in muscle. And we know that exercise, increasing metabolic, rate, we know that a good quality diet, those things actually decrease myosteatosis, which actually increases muscle strength. Exercise increases bone strength, decreases fracture risk, osteoporosis, decreases frailty. And, one of the major reasons that people end up not being, say, even liver transplant candidates or just doing poorly functional status-wise is because of frailty and just some degree of exercise, not overdoing it, but some degree. I do want to warn, though, we don't want our patients with what we call portal hypertension, which is the buildup of like fluid and blood vessels in the advent and, varices and things like that, lifting more than very, very minimal weights, because increasing abdominal pressure with weights can actually increase risk of bleeding. So we have to weigh that with sort of the benefit. And just so I would say anybody that has cirrhosis who wants to exercise and should exercise should actually probably at least work with some sort of a trainer or an occupational physical therapist who's used to working with our patients to get some ideas on safe exercise. So we don't want people to get hurt either.
Not many
So-
patients have access to personal trainers or physical
Yeah, no,
therapists.
that's the tough part. There are websites. I often will tell patients, because I'm a big proponent of Pilates, which I think many people could do. And a lot of the same sort of exercises that are recommended for pregnant women, especially more advanced pregnancy, would be similar to things that somebody, say, with cirrhosis should do, because obviously a quite pregnant woman is not going to want to increase abdominal pressure and lay prone on their bellies and things like that. So that's something, but there are lots of websites about that now. So
No sit-ups for cirrhotic patients.
yeah, no sit-ups and
No
crunches.
setup. Okay.
Yeah, one thing I want to add here too would be over-count supplements.
That's a
And
good-
many patients are taking supplements. Unfortunately, this is a relatively unregulated field. And a lot of time the advertisements can be misleading. And they label liver protection, but they're not liver protected at all. And some can cause liver problem too. So I think in general, if you want to take a supplement, I think multiple vitamins, calcium, probably fine. The other things, you probably have to consult your doctors.
The other question is, at what stage of cirrhosis the disease can be reversed and the need for transplantation can be eliminated? Any stage of cirrhosis or not?
So I maybe I'll just take that first. So I think that, when I was training, it would have been, almost blasphemy to say that you can reverse cirrhosis. But we know that actually we can. I mean, I've seen patients, say, who had well-known cirrhosis, say from hepatitis C, who later developed liver cancer, had a liver transplant, and the fibrosis was minimal at that point. So we can reverse it. Obviously, the more advanced the liver disease is, the less likely to reverse, I would say, the cirrhosis to the point of not having cirrhosis, and also becoming clinically well enough to, say, not need a liver transplant. So for instance, hepatitis C, if somebody has very advanced hepatitis C, we tend to treat them after a liver transplant because we probably can't make them very functional again. But I want to mention, though, that if somebody ever had cirrhosis and then they don't have cirrhosis anymore by any non-invasive or invasive measure, their risk of liver cancer doesn't go away. And so it's very important for those people still to be in some sort of a liver cancer surveillance program. Now, there may be arguments into what that should be, but I think any patient out there should at least recognize that once you have cirrhosis, it's not like you're out of the woods completely, and things still need to be followed, because I know that Waleed and I know that Kachin have seen many patients that sort of had reversal of fibrosis who later came in, or just very stable liver disease, who didn't get surveyed for cancer, who then came in with cancer. So
yeah, I mean, Jeff, we see it a lot with people who have alcoholic liver disease,
Yeah.
presenting with early cirrhosis.
Same thing.
They start drinking.
Yeah.
In a few years, the scar tissue start reversing. But I just have to caution, this is not the norm. This is the exception. I still find it.
Oh, it's the exception,
It
absolutely.
is the exception, not the norm. Majority of the people will progress and eventually end up needing a liver transplant. But certain cases, there's exception.
Yeah, one thing is a lot of I see my patients sometimes misunderstood description. When we talk about fibrosis or scar, we have stage. a stage 0 to stage 4, stage 4 cirrhosis. A lot of time patients ask me, I have stage 4 cirrhosis. No, when we have cirrhosis, we don't have stage further. We have cirrhosis, early cirrhosis, or cirrhosis without complication, or cirrhosis with complication or decompensation. So once they have stage of cirrhosis, as Dr. Kang mentioned, we use child score, med score. We don't have further stage anymore.
Mhm. Has there been cases when you have a liver, you have cirrhosis and get the liver transplantation, the cirrhosis come back again with the new liver, or that's done when you do liver transplantation?
It depends on the disease. So certainly in somebody with alcohol-associated liver disease who gets transplanted, if they don't drink, unless something else happens, unrelated, will not end up getting cirrhosis again. With Hep C, we used to see patients, I saw a patient with Hep C who had cirrhosis within a year after transplant when we didn't have treatment for Hep C. Now, I mean, we treat everybody after transplant if they haven't been treated, and we don't see it coming back. The autoimmune liver diseases, especially PBC and PSC, can come back. And, you know, I've seen some patients with PBC who even needed to have a second transplant. Not commonly, but it's certainly possible. The genetic diseases don't come back unless they happen to be unlucky enough to get a liver that had the same genetic disease. So Wilson disease is cured by a liver transplant, and hemochromatosis and alpha-1 antitrypsin deficiency and other genetic diseases. But it can be a little bit more complicated, but in general, you know, those are the diseases that tend to come back. So
to summarize it, if the cause of the liver disease is treated, then the disease doesn't come back. You know, with autoimmune disease, usually there is 15 to 30% chance that the disease will come back after transplant over the life of the graft. But overall, if you treat the underlying disease, you stop alcohol, you treat hepatitis C, for example, the disease doesn't come back. Even with hepatitis B, as long as you're treating hepatitis B and you keep the virus suppressed with a medication. And that's very important. A lot of patients believe that, you know, once they get a liver transplant, they don't need to take the medicine for hepatitis B, and which is wrong. If they stop the medicine, the disease will come back and destroys a new liver.
Question is, can I take it, and the audience has that, can I take over-the-counter pain medication if I have cirrhosis? And the two questions kind of related, kind of not. So let's answer this one, and then I ask your last question. Can they take over-the-counter painkillers like Tylenols, anything that we normally take?
I'll take this first. Okay, so yes, patient, as long as they're not drinking alcohol, even they have cirrhosis, taking Tylenol is in general be safe. But you probably have also a certain amount, you don't take it too much too. And so that's Tylenol. People, when they have cirrhosis, they may have some gastritis too. So their tolerance to aspirin type of medicine, Motrin, could be lower too. They may have got stomach upset. They may actually cause risk of bleeding too. So be careful of that too. Of course, they have sometimes they have severe pain too, and they may take even like a morphine type of medicine too. So I think we have to balance that too, to keep in mind. The pain medicines, especially morphine type, are cleared by liver. It can cause confusion if they already have encephalopathy. We'll talk today too. So be careful about that too.
Yeah. Dr. Ayub?
I mean, over-the-counter medicine are usually safe. Patient with cirrhosis, we tell them it's okay to take Tylenol or acetaminophen. Just need to keep the dose at, you know, maximum dose at 2,000 milligram a day in divided dose. You cannot drink because alcohol mixed with the Tylenol will increase the chance of causing liver damage from Tylenol on the liver. The other class of medicine, we call them NSAID. We don't like in patients with cirrhosis because they could harm the kidney, and they also interfere with with a cascade of events that cause portal hypertension, the pressure inside the liver to go up, and that will secondarily lead to worsening kidney function. So we, a narcotic are usually not available over the counter, but even prescribed narcotic we do not like because it could lead to portosystemic encephalopathy. So we don't like those. So we prefer Tylenol or acetaminophen #1 within restriction.
Dr. Khan?
I agree with what was said.
So the last question is, can a patient who has severe encephalopathy get his normal brain back after treatment for cirrhosis or transplantation? What are the damages that encephalopathy can cause, and how the patients can fight it and get back their normal brain?
So in general, a transplant would cure encephalopathy. There are cases, though, those veins that I showed you earlier, that those collateral vessels that are opened when somebody has cirrhosis and can cause variceal bleeding, and that spontaneous shunt I talked about, they don't go away completely. So for instance, we've seen patients after transplant develop, say, a clot in the vein going to the liver, after transplant develop encephalopathy, because then the blood's trying to going back through those vessels that were already open. So there are instances where the encephalopathy can come back. In cases like that, you'd want to make sure that there aren't any clots in the vein going to the liver. The more dense the encephalopathy is and the longer lasting before transplant, the less likely somebody is to come back to a normal state afterward. That said, most of our patients with encephalopathy do come back to at least in my experience, quite a normal state. There are some other brain manifestations which I didn't really talk about. Something called hepatocerebral syndrome and some other brain syndromes related to the liver and cirrhosis, and some of them are nutritional.
I think we kind of lost Dr. Khan.
I think what Dr. Khan was saying, after the longer and the more difficult to control encephalopathy is before transplant, the more likelihood there will be some remnant side effect of encephalopathy post-transplant, whether it manifests in some memory problem or other form. It's not that common because we are good at treating encephalopathy now, but it is for the people who stays with uncontrolled encephalopathy for a while, that the chance might be you'll have some remnant effect of encephalopathy after transplant. Now, for patients with cirrhosis, we're talking about the supplement. They tend to have a low level of zinc, and zinc is required for the breakdown of ammonia in the blood. So it's quite common to recommend zinc supplement for patients with hard to control encephalopathy.
Dr. Hu, you want to
Yeah,
ask?
I agree both comments here too. One thing is, hepatic encephalopathy is a functional problem. It's reversible. If cirrhosis shunt, the conditions are corrected too, it's going to be reversed too. And usually does not cause permanent liver brain damage. That's very different than other organic brain problem.
Well, thank you so much. This was a wonderful conversation, and you answered Dr. Khan's presentation. I think we've lost the connection with him. Was wonderful, was very detailed. So I want to thank all of you for donating your time and talent and experience to help liver patients. We hope everyone has received new and important information now. So thank you, Dr. Khan. I'm sure your wonderful presentation has given new information to people who need it the most. Thank you, Dr. Ayub. Liver Health Foundation is grateful for your partnership and guidance. We appreciate your continued support. Thank you, Dr. Hu, about all you are doing in Orange County and beyond to support liver patients and support our work. Thank you to Mallinckrodt Pharmaceuticals for the educational grant that made this possible. Thank you, Salix Pharmaceuticals, for your grant and support of our educational webinars. Please join us on December 12th for another educational webinar on biliary atresia. Our speakers are Dr. Rohit Kohli from Children's Hospital, Los Angeles, and Dr. Kambiz Etesami from Keck, USC. During the webinar, our expert will try to respond to your questions. Liver Health Foundation is on all social media sites, and we announce our events and programs there. Please join us. Thank you for joining us this evening for this important webinar. We hope to see you on December 12th for biliary atresia webinar. We wish you a happy and safe Thanksgiving. Be well, take care, and good night.
Thank you. Thank you all.
Thank you so much.
Bye-bye.